Okay, we got a pretty good crowd here, so I think why don't we go ahead and get started here? It's 12:04. So welcome everybody back to the Primary Care Grand Rounds. Today we have our most popular guests, Kelly Wark and Megan Klatt from our Disease Division, who will be talking to us today about a variety of infectious disease topics. So formally UTIs and measles, but I think we'll have some time for whatever questions you have around infectious diseases, right? So, with that, guys, I will turn it over to you.
Okay, perfect. I um can you guys see that okay?
Yeah, we can see that, Kelly.
Okay, perfect. So, yes, and a big part of our discussion today is going to actually be on duration. So, Megan and I, in addition to our work at KU, we both are the co-leads for at KDHE, the antibiotic stewardship program. So this is Antibiotic Awareness Week, started the 18th and it goes through the 24th. So we're just kind of doing, that's kind of why we volunteered ourselves this week to talk about antibiotics. And our theme this year is shorter, is better. And so we actually, I got a picture here of us. We actually got to meet the governor a couple weeks ago. She did an in-person signing, and so she declared this week that Kansas recognizes antibiotic awareness, and so that was kind of nifty. You can see myself, Megan, and then Eric are there, and then this is the KDHE team. And then a partner from Kansas Foundation for Medical Care as well. So yeah, kind of nifty there. This is actually our 7th year marking this gubernatorial proclamation. And so this is the first time though that we got to like have like an in-person signing and stuff. So was going to talk about durations, kind of like the background of where these durations originated. So interestingly, around the time when penicillin was discovered, like shortly after it was discovered, it was actually really they were treating people for pneumonias with like 1 to 2 days, basically, of penicillin. And at most they were treated for like 3 to 4 days. And so then, then we started to get into these longer durations of like, 14 days or even like month long. And it was like, where did that come from, right? So it really didn't come from anywhere, actually. It really, well, I mean, it came from somewhere. There was a lot of, it was a different world back then with like the FDA and how they worked. And then, for example, the FDA director of antibiotics was actually the editor for the Journal of Antibiotics, and then another one, Journal of Antimicrobial Chemotherapy. So they really only pass things as long as they were safe. So they didn't look at like efficacy necessarily. So if it was safe, got the FDA's approval. And what was happening is that the FDA director, I think his name was like Henry W something, got embroiled in this scandal because he was actually getting kickbacks for like it amounted to today's dollars, millions of dollars, because he was allowing all these advertisements in his where he's the editor journal of these two journals. So this is like a huge scandal. They really started to do some reform at this point, and that's when they really started to incorporate more looking at efficacy. But this was like rampant that they were advertising in these journals, specifically to clinicians, encouraging really longer durations, because like, why would you want to just treat something with like 3 days? They're going to make money if they have 14 days. And so this is really like this golden era of antibiotics is when these longer courses really started to happen, but it really never was based on any like literature or anything like that. Then we start having a lot more emphasis on guidelines, and especially in the 90s and early 2000s when antibiotic resistance really started to increase, there was a lot more attention for these durations. And so that's when really since the early 2000s is when we'd had a whole lot of studies that have been published looking at the durations. And oh, sorry, I got kind of cut off here on the right side. But since 2000 onwards, we'd have had over 120 randomized trials looking at a variety of different infectious disease conditions. A lot of these, so Megan's going to talk a lot about the UTIs, those are a lot of them, and pyelonephritis. But there's been a lot of studies for pneumonias, for ventilator-associated pneumonias, intra-abdominal infections, skin infections, cellulitis, even sinusitis, otitis, osteomyelitis, diabetic foot ulcers. So a lot of things that really are showing that we've been treating these infections way, way, way too long. And then this is also another interesting article. So kind of this mantra, if you've heard of it, the shorter is better. This came out of Brad Spellberg. He's an ID physician at UCLA. And he kind of, I think, coined this term. He has a website, if you guys have ever visited, shorter is better. And he lists like a running tally of all the literature for this and stuff too. So if you have any condition, you could just go over to Brad Spellberg's Shorter is Better website, and you can actually see the citations there. But he published this kind of interesting article where he acknowledges that basically, why are we doing, we seem to do durations in increments of 7. And so suggested that had Constantine not made the week 7 days, but instead if he had declared it 4 days, indeed we'd probably be treating with 4 days instead. So it's all just a little bit arbitrary, basically, is what we've been doing for a long time. So now we'll get into kind of like the duration talk with a variety of different kind of conditions. But the first case I had is actually community-acquired pneumonia. So Miss Cap is a 60-year-old female that's otherwise healthy. She comes to clinic. She's had 5 days of worsening shortness of breath, cough. She is febrile in clinic to 101. But otherwise normotensive. She's like mildly tachycardic. She's on room air with good sats. You were able to get some labs after the visit that showed a mild leukocytosis and a chest X-ray that showed a little bit of a left basilar consolidation, and then COVID and flu were negative. So what type of antibiotic, but specifically duration, might you aim for her CAP, basically her CAP treatment?
We're looking for interaction here, Kelly.
Yeah, go ahead. I'm just getting bolted. Sorry if you can hear that in the background too.
Yeah, I mean, I'd be looking at, Zithro or Doxy probably at 5 to 7 days.
Yeah, I was gonna say like Augmentin 5 days.
Yeah, I think that, I mean, that's a pretty good duration, would be 5 days. That's kind of what we've kind of moved into, is getting that 5. I would say maybe we used to aim more for 7. And so actually ASIP, or ACP, I always call it ASIP because I'm so used to saying ASIP, but anyway, they actually put out their clinical guidance for these most common conditions a couple years ago in 2021. And so they I don't know why they did, so they did 4 to 5 days. And we'll see as we go through this, actually 3 to 5 days is what the guidelines say. So pneumonia, 5 days, they call out. So limit it to 5 days. There's some caveats. Obviously, if you have a person that's really, has, bronchiectasis, or they have cystic fibrosis, or they have some immunocompromising condition, or if they have, a very long, caveats, of course, but the basic cap, 5 days. And then for UTIs, 3 to 5 days. And then, and this also aligns with the guidelines that just came out actually this summer, which is what Megan's going to also touch on. And then for cellulitis, 5 to 6 days. So the first one we were going to talk about is pneumonia. So this was a systematic review where they looked at like over 14 randomized trials, included over 88,000 people. They were both adults and pediatric, and adults with comorbidities as well. So they looked at treating them with either 3 or 5 days of antibiotics compared to their comparator, which is the 14 days of antibiotics. And so they found that there was no difference in, in cure. So basically they both were getting pretty equal cure. They looked at many of these studies, this is a systematic review, but many of these studies did look at long-term outcomes up to like 2 months to look at recurrences. They looked at mortality, no increases in mortality. There hasn't been as much a literature where they looked at antibiotic resistance, but the literature for the VAP shows that the shorter durations tend to have about a third less risk of drug-resistant infection carriage. And so really, this is where it started to kind of get into the guidelines that we can do these shorter courses, even for CAP. And then, obviously not going to go through these, but these are some of the citations and stuff that have done these, that's looked at this. And this isn't the standard of care yet, but this is also just one I would like to point out, is that for atypical pneumonia, actually, there was a trial where they looked at, Legionella or Mycoplasma type infections, confirmed pneumonias, and they gave the short course of 1 day, but that was a 1.5 grams of the azithromycin, so pretty hefty dose, compared to 3 days of the 500. So basically the same dose, but it was just given in 1 day instead of 3 days. And it was equal cure. So 98% were cured in both arms. So again, this is not in the guidelines or anything like that. But as we, this is just something to keep in mind, that probably as we go along, we will see more and more kind of caveats to these kind of durations being cut down. Any questions on the pneumonias? I didn't cover VAP because it's not really, so much applicable to that, but that's an interesting one that's coming out too, for shorter durations for that one.
So Kelly, I don't have a question necessarily on pneumonia necessarily, but just a general principle. So I think, if I go way back to med school, I believe I was taught that part of the reason why you don't want too short a course is that if you don't kill all the bacteria, then they get resistant, which was the rationale for making sure that we treated for long enough duration. But it sounds like that's just not true. But you kind of hinted at that. Can you talk a little bit about maybe some of those myths and then, just that resistance piece a little bit more, if you can?
Yeah. So when looking at, it seems like it's probably more critically, so the longer you're doing the antibiotics, of course, there's more pressure for those, you're killing off whatever pneumococcus you want, but then the resistant pneumococcus is surviving. And so that's what you end up with. And the longer course you do, the more likely that's what you're going to end up with predominantly. And so that's just kind of the, obviously the thought process for why these longer durations do it. Like I said, there's not like a super lot of CAP literature suggesting this, that it increases resistance with longer courses, but there is quite a bit of other literature for other conditions, specifically around like the ventilator associated. And so there's also some literature that suggests shorter durations, but higher dosages. So there was a study where they looked at community-acquired pneumonia, and it was a confirmed, I think this was in children actually, with Streptococcus pneumonia, and it was a 5 days of amoxicillin versus 10 days of amoxicillin at a standard dose. So the high dose amoxicillin cured them, but actually that population had around, I think, 25% less resistance of the strep pneumo resistance. So they got, 5 days of a little bit higher dose compared to 10 days of the standard dose. Both got cured, but the group that had the shorter duration ended up having less resistance. And so, that dogma of where, it was like, take your course till it's done. And at first, when we started at KDHE too, like that was the messaging around, like, the CDC too, like, do what the doctor says. I will say, and I've even asked that, I think Megan, you were there when we talked to the CDC people, and we're like, we've kind of been not encouraging that for several years. And she said, we at the CDC no longer have that out in our commentary now. We're not saying don't follow, the physician's recommendation, but that old comment of, take it until you're finished, because so many of these courses are so long that that's kind of fallen off the wayside, actually. So you're probably not going to see that kind of commentary so much in like public health stuff anymore.
Yeah, it was actually quite comical when we did the governor signing. When we were talking to
Yeah.
The governor, she was like, "Oh, antibiotics, I'll take my full script," and all of us just went.
I know. We were like,
we were like, well, we only have a minute with you, so we're not going to say anything. But it was kind of comical, yeah, because there's just so much literature out there now that you don't need 14 days for sinusitis, and so yeah, maybe you shouldn't take your full prescription if that is in fact what they've ordered for you. I just thought that
yeah,
was funny, a little.
I know. Yeah, it was kind of ironic, but
This is like a complete aside, but I do feel like it's become the point where patients used to get frustrated at like, oh, no antibiotics. That like whenever I get a sinusitis, I always get antibiotics. And now it's like, well, my old doctor used to do 10 days. And so why are you giving me 5? And so it's like a brand new argument that we have to come up with of like, oh, it's just we're always fighting ourselves, I feel like.
I know it is a struggle when like historically they've tended to get longer courses and then they think that you're kind of like gypping them or not treating them adequately based on what they're historically they've gotten for their maybe older trusted physicians. And then I think actually towards the end, Megan and I are going to show you some of the stuff that we created for kind of some posters, but also a new decision script pad, and then the the GU one, that is for like recurrent UTI symptomatic control, and then the upper respiratory too. And we have some dot phrases and stuff for that too, just to remind you. We put them in the office like maybe a couple years ago, but maybe we should refresh them, because we're actually using them more and more in ID. And they've started to become so popular that we're creating more script pads. The patients really seem to like them too. So I'll drop some fresh ones off for the internal medicine clinics and contact me if you want some.
Yeah, somebody was just asking me that. Yeah, I think we got a lot of our family med colleagues on here too. I'm sure they would appreciate that. But,
Yeah.
we got a question in the chat here. So when patients call you back and note that they still have some mild symptoms, what do you suggest to them? Just continue conservative measures and watch for fever or worsening, or?
Yeah, and I guess it depends on what like condition you're talking about. Like so if they're having like if they're having pneumonia and they're still having cough, then I would say, yeah, so that also is part of that script pad, that symptomatic, and it gives a duration of how long you can anticipate symptoms to last. So it's, I think, also helpful at the beginning to say, you had an infection, this affected your body. You may not have complete resolution of your symptoms by the end of the course, but that doesn't mean your infection wasn't treated. Setting that expectation early might be pretty helpful. That's usually what I do too with cellulitis. People that have like really bad redness, and I know that it's not going to be back to normal in 5 days, but the infection's gone, but they're still left, and you guys see this, they're still left with this kind of non-blanching, non-warm chronic erythema that ends up lasting like another month. That's not infection. That's just like, they had so much blood, like they had like hemostasis, and it's, you press on it, it's not blanching, it's not warm. So just like, I will say that a lot of times when I see people with super bad cellulitis, I'm like, yeah, this redness isn't probably not going to go away for some time, but that doesn't mean that you still have infection. So that's kind of my approach. And I think that generally they seem to accept that. And yeah, I don't feel like that I'm scamming them or anything like that. And then I always give them the symptoms to look for too. I said, yeah, if you're seeing increased redness, increased swelling, increased pain, if you're feeling feverish, chilled, sweaty, et cetera, that type of thing is where you think that the infection might be back. And then we would need to extend or resume antibiotics.
Is the
So
better part, is that true too in our immunosuppressed population? And maybe some of our like multiple comorbidity patients and stuff, or
multiple comorbidities, yes, but like there certainly is some caveats for like the pneumonia. If you're talking about someone that has like I said, cystic fibrosis or chronic bronchiectasis, that might be a population that's not generally, but for the average, comorbidities with COPD and diabetes, then yeah, that would be a reasonable or is recommended. If you're talking about people that are very immunocompromised, like, that have had like bone marrow transplants and stuff like that, or organ, solid organ transplants, actually Chelsea Gorsline is our kind of our ID steward, as our immunocompromised transplant ID, and she's working on kind of this initiative too to kind of cut down on these durations. So, correct me if I'm wrong, Megan, but yeah, generally speaking, there's no specific longer course just because they're immunocompromised in any specific population. Besides that I said, be cautious about like cystic fibrosis.
Yeah. The unfortunate part is they're never included in those studies. And so that's the kicker, is that they're not included, so we don't have the data to support it. And everybody's always cautious because it's like, well, they didn't include my patient population. It's like, well, I've seen people who have improved after 7 days. It's probably okay, given they had resolution of symptoms, they're afebrile, their white count is, well, for immunosuppressed, the white count doesn't obviously follow the normal, but we're really trying. It's hard when you don't have the primary literature to support it, but there is ongoing work in that space too, which is exciting.
So the next one is skin infections. This is definitely one that we see getting a lot, like long courses of antibiotics. And this was both, again, adults and peds. It was actually 4 randomized controlled trials that they looked at, over 1,400 people. And so they compared these 5 to 6 days, and they were non-inferior to the 10-day course. This being said, this is like, again, this is the general cellulitis. It's not someone that has like pus coming out of their wound, or they're having like you're concerned they're hospitalized or concerned with a necrotizing infection, or this is more like your impetigo, your clear kind of erysipelas type cellulitis. And then, oh, oops, I must have moved this wrong. I think I mentioned this though, longer courses, getting back to the cap. So longer courses, there are some bugs too that would necessitate longer courses, possibly. There's been some questionable data about Pseudomonas, and they had maybe increased risks of recurrences if it was shorter conditions, although some other studies show they didn't. So that's a population where you would determine, depend on how much they're improving clinically. If they're very slow to improve, they're still having fevers, or they're still not, breathing back to baseline, that's a situation where you would want to probably extend that more to the longer, to the typical course. And then, of course, if someone has empyema or abscess or necrotizing pneumonia or something like that, that's completely not appropriate for a shorter course. It's just kind of, the basically like 90% of the cap that we see though would fit into your typical kind of sufficient 5-day. So the next one too is sinusitis. And I find this really interesting. So, this is like, this is also helpful on that script pad that Megan's going to go over, is for like symptomatic management. Because as we all know, it's just such a minority that really are caused by bacteria. But there was a meta-analysis where they looked at 7 randomized trials for people that got antibiotics versus not antibiotics. These are actually what they called bacterial sinusitis. So not, they weren't looking at viral. They gave one group actually no antibiotics, placebo. It was double blinded. So the patients and the providers didn't know they weren't getting antibiotics. They were getting something where they thought, who knows what they thought. And then the other groups that had got the antibiotic, they actually found that the antibiotic group, so they got better cured with it. 77% of that population that got antibiotics got cured, but 68% of the group that didn't get anything, that got placebo with their bacterial sinusitis, got over symptoms. So, I think this is like important to also think back, is like how many infections actually do just, kind of resolve on their own. And so that's also, I think, where we talk about this like watchful waiting, is like, that is the most important part, is like to just like emphasize, hey, these are the symptoms to look for if you're not improving, if it's by this time, if you're starting to have, you're starting to have a headache, you're starting to have like low grade fevers, you're starting to feel chill, blah, blah, blah. That's at the point when then you can let them know to, follow back up with you. And even adding this comment that, there's a good like 2/3 of people that had bacterial sinusitis cleared on their own. So even if it is starting to go into bacterial, chances are you are going to just clear it by yourself. Again, I'm not saying that if you had someone that had bacterial sinusitis, you would still treat it, but this is just kind of an interesting kind of component that many of these, who knows what we're actually curing, they might be just getting cured by themselves. Okay, and then I'm going to
Sorry,
pass it over to
Ted.
Megan for UTIs.
Can I ask a quick question
Yeah.
about the last slide? For the
Mhm.
sinusitis, did they talk about like symptomatic improvement, not just like general infectious improvement, but just like did they feel any better, quicker with antibiotics versus placebo?
Yeah, this was like, since it was like a meta-analysis, I'd have to go back and look at that one and pull that data out to see if there was like a faster symptomatic improvement with the antibiotics than the placebo. I can't off the, yeah, not sure off the top of my head. But surely some of those 17 trials definitely would have like pulled that out. I'll let you know, John, when I go back. I'll check it out for you.
Thanks.
Okay. All right. Oh yeah, yeah. And Megan, just let me know to advance it and I can move it for you
Perfect.
because I'm
Thank
sharing
you.
the screen.
Great. So yeah, moving on to UTIs, I would say there's probably the most amount of literature in the UTI space.
Okay, you too.
Shorter is better. And so since 2007, we've had over 9 RCTs that have looked at shorter is better. So usually the 5 to 7 days being short courses versus the historical standard of 10 to 14 days. And they've found essentially no difference in the rates of cure. I do want to note that we're going to talk about this later, but these studies had a very different definition of complicated UTI compared to how we now in 2025 define complicated UTI. So we'll walk through that in the next couple of slides, but essentially short courses are definitely recommended in patients who have urinary tract infections. Next slide. This slide details some of the literature. I'm not going to go over every study. I do want to highlight that, as you can see in the bottom here, some of the more recent data is really focusing in on fluoroquinolone-based regimens. And so I would say our most robust data in this space for short courses are using our fluoroquinolones as opposed to oral beta-lactams or other agents. Next slide. And then just wrapping up with diabetic foot infection. So this was a study by Pham and colleagues looking at moderate to severe diabetic foot ulcer without osteomyelitis. And they compared 10 versus 20 days. Essentially, they all got about 1 day of IV lead-in, but then switched all over to oral therapy. And they found no difference in cure rates compared to that short versus long. There is a larger study underway that's going to confirm, hopefully, these findings. Next slide. So we've talked a lot about the data to support shorter is better, but there's also a benefit in shorter durations in reducing the risk of antibiotic harms. So we're well aware that antibiotics are associated with harms, but there's really limited literature to actually quantify that attributable harm risk associated with increased durations of therapy. So this was an analysis by Curran and colleagues. It included over 30 systemic reviews and included over 23,000 adult and pediatric patients. And essentially what they found as it relates to adverse events was that with each additional day of antibiotics, you had a 4% increased odds of experiencing an adverse event, and that increased to 9% for severe adverse events with each additional day. Additionally, when they looked at antimicrobial resistance, each additional day was associated with a 3% increased odds of resistance developing, and then a 2% increased odds of secondary infections. So to compare some treatment courses here for you, let's say you're doing 3 versus 5 days. That additional 2 days yields about a 10% increased odds of a patient experiencing an adverse event. You increase that even more to 7 days, and you're doubling that to about a 20% increased odds. So again, as I tell all of our pharmacists inpatient, every day counts, every day matters, not only in preventing or treating an infection, but preventing some of these undue toxicities with patients. Next slide.
And we had a red arrow, but it got lost. Sorry, Megan.
Yeah, no worries. Increase, not decrease.
Yeah, it was a great increase.
Okay, so we talked a lot about the data. How do you actually implement this in your clinical practice? There's a lot of different ways to do this. We'll focus really on EHR modifications and guidelines and incorporation into clinical decision support today. Next slide. Okay, so this is one of our favorite studies. It was a very simple but effective tool to nudge providers on appropriate durations of therapy. So this was a pre-post intervention that specifically targeted ED and clinic patients in a children's network in Chicago. And what they did was really simple. They added some duration of therapy buttons. They could either select 5 or 7 days or 10 days of therapy for the following different antimicrobials. And what they found was that antibiotic duration was reduced by about 5 days, and there was less prescribing of 10 to 7-day durations when they implemented these order buttons. Next slide. Also, importantly, there was really no increase in reorders of the same agent, return clinic visits, or inpatient admissions. So like I said, this is a really great example of a low-cost, low-effort intervention that we could implement here at KU. And there's also a lot of different EHR tools that are out there, like stop dates, IV to PO transitions, and such. That is usually available through Epic. You just need to add on the feature. And so that's something that we're looking into for sure, trying to figure out ways to optimize the EHR to make us, like I said, work smarter, not harder. Next slide, please. Okay, moving on to guidelines. Institutional guidelines can be really helpful to provide institution-specific guidance that is tailored based on our own local susceptibility data and provider prescribing habits. So this is the implementation of UTI guidance, and essentially, as you can see, by implementing these guidelines, they reduced their overall duration of therapy, and they found no difference in rates of clinical failure overall, or when stratified by the different durations that they used for these patients. Next slide. Okay, so this is the fun stuff. This is new data, new information. Just this year, actually just a few months ago, the IDSA released their new guidance on the management of complicated UTIs. And it essentially aligns with how we've been practicing in the inpatient setting for a while, but just puts the pen to paper and confirms that this is new national recommendation. So they had a lot of updated guidance, but what we're going to focus on today are the classifications of complicated versus uncomplicated UTI. So uncomplicated UTI is now defined as any infection confined to the bladder. That is regardless of sex, so no more considering males as complicated UTIs and comorbidities. So there's always that caveat that patients with diabetes are complicated UTIs. No more. If you have an infection of the bladder, you have a uncomplicated UTI, and that is the definition. Complicated UTI is any infection that has systemic signs or symptoms like bacteremia, fever, flank pain. Those patients have a complicated UTI, and that's also any patients who have upper tract involvement, so essentially pyelonephritis. Complicated UTI also includes patients who have catheter-associated infections or CAUTIs. Next slide. Okay, so case number 2. We have a 45-year-old gentleman who has diabetes, who is seen in clinic with 2 days of flank pain and fevers. His UA is suggestive of an infection. He's afebrile and normotensive, has mild tachycardia. What would you plan to do in terms of antibiotics and their duration?
I feel like I would give this guy like a one-time IM Rocephin in clinic and then follow it up with like 4 days of Cipro or something like that to cover it. Cipro or Bactrim or something.
All right.
Yeah, well, I've been thinking maybe some nitrofurantoin. And before today, I would have done 7 days, with the flank pain and all that.
Yeah, I would consider this a pyelonephritis case. So a complicated UTI, also using the appropriate nomenclature now, considering that he has more systemic involvement. So I probably wouldn't do nitrofurantoin because it's not going to get into the kidneys. I do like the idea of the IM ceftriaxone plus some additional days of an oral antibiotic. Based on our local susceptibility data, fluoroquinolone could be very reasonable, and then we try to do a short duration of 5 to 7 days. We could also do an oral beta-lactam, probably after getting susceptibility results to confirm that. But yeah, short is better, as we are going to continue to repeat. Yes. bacterial prostatitis is definitely an exception to that rule. That is something that would require multiple.
Yeah,
Go ahead,
yeah.
Kelly.
This one we specifically called out in our guidelines that if they have prostatitis, that's like its own entity. So so these guidelines do suggest I think they call it like an uncomplicated prostatitis for a minimum of 2 weeks. So you could consider 2 weeks. So 2 to 4 weeks would be the prostatitis if that's what you were considering there.
Did you guys see the other question in the chat around some patients don't want to wait for a urine culture, so they have to start empiric therapy, and then any suggestions on which antibiotic in this case if you have no prior urine culture information?
Yeah, I would probably do, like I said, an oral fluoroquinolone up front. Based on our local susceptibility data, you could consider like an oral cephalosporin. I probably wouldn't do that first line for like a pyelonephritis picture. I like the IM ceftriaxone ×1 while you're waiting for that. Just because it can be variable in terms of the rates of susceptibility based on those agents. So my preference would be probably a fluoroquinolone if possible. Again, for complicated UTI. If we're talking uncomplicated UTI, nitrofurantoin usually has high susceptibility rates. The issue with that is just concentration into the renal parenchyma. So it's not going to be adequate for the treatment of a complicated UTI or pyelonephritis because you're not getting high enough concentration in that space. Same thing for fosfomycin, why we only limit that to cystitis as well. And then we'll talk about, again, not for a complicated UTI, but we'll talk in the next couple slides for cystitis, the use of a single dose aminoglycoside. That's now kind of one of our go-to agents. It's a one and done option for patients. And so that's really nice for those that potentially are not going to want to follow up and just want something to treat their UTI while they're in clinic, one and done, move on with their lives sort of situation.
So yeah, if Mr. Rudy, if the same scenario, but if we remove the flank and the fevers, then yeah, he'd be looking at the nitrofurantoin.
Yeah, for sure.
For 5.
Awesome. So this is an example of guidelines that incorporate this new guidance. So again, uncomplicated UTI or cystitis, we're treating with nitrofurantoin for 5 days as our preferred agent. Alternatives being trimethoprim sulfamethoxazole or Bactrim for 3 days, and then an oral cephalosporin is also a reasonable option. You can obviously do a fluoroquinolone as well, or a single dose aminoglycoside, and we'll talk about situations for those next couple slides. Again, new complicated UTIs, so that's pyelonephritis, CAUTI, or any upper tract involvement or systemic signs or symptoms. We're starting patients off, at least in the outpatient setting, with the fluoroquinolone. If you're inpatient, you're probably getting ceftriaxone is what we recommend. But then once we have susceptibilities, we narrow down to orals whenever possible. Alternative therapies, again, trimethoprim sulfamethoxazole or oral beta-lactams for patients. All right, next slide. Okay, and then just some organism-specific information. We always like to plug these particular situations because they're kind of unique exceptions to the rule where we can use some antimicrobial stewardship principles. And honestly, from a pharmacist standpoint, some really interesting like PK/PD, medchem techniques to ensure patients are treated adequately. So for vancomycin-resistant Anaerococcus, providers often think that your only options here are daptomycin or linezolid, when in fact, for the treatment of UTIs, we can usually get away with a high dose amoxicillin for these patients. The theory behind this is that in these particular situations, we're just saturating penicillin binding proteins. And so we can just give really high doses that achieve high concentrations in the urine, and you're able to overcome those higher MICs for a therapeutic effect. So that's a specific bug drug combination that we like to plug. Additionally, for ESBL E. coli in particular, there is some data to support the use of fosfomycin. I'll note that this is specifically ESBL E. coli, not other ESBL gram-negatives. And again, since fosfomycin only concentrates well in the urine, not and in the bladder and not in the renal parenchyma, we wouldn't use it for a complicated UTI ESBL. And this is obviously in the setting of a patient who is without other oral options, and we're trying to do IV sparing therapy. Next slide. Okay, so everybody's favorite single dose aminoglycosides, or at least Kelly and I's favorite single dose aminoglycosides. So what is this? How does this work? So aminoglycosides, tobramycin, gentamicin, amikacin, are very unique in that they are primarily excreted as unchanged product in the urine. And so a single dose of tobramycin or amikacin can achieve urinary concentrations far above the peak to MIC ratio needed for a therapeutic effect. And those concentrations are sustained for a typical UTI, specifically a cystitis treatment course of about 72 hours. There's some good data on the use of single-dose aminoglycosides. It shows that they are highly effective in reaching about 95% microbiological cure, and the rates of toxicity are very minimal. 0.5% nephrotoxicity and vestibular toxicity rate. I will say that we do this quite a bit in the urgent care, or not the urgent care, but the ED setting, and also in ID clinic. And I have yet to see a patient who has had nephrotoxicity or vestibular toxicity associated with this dose of aminoglycoside. It's also really nice because aminoglycosides tend to have pretty good empiric activity against a lot of our gram negatives, including resistant species like ESBLs and Pseudomonas. So logistics, how do we do this? We recommend a 5 milligram per kilogram dose. It can be given intravenously or via IM injection. If you're giving it via IM injection, we recommend dividing the total volume into 2 to 3 IM injections. And we say personally that we wouldn't go over 12 mLs if that's the weight-based dose, ends up being around 12 mLs, because it just ends up being over 4 injections for a patient. And I don't know about you, but I probably would draw the line at 4. So that's the kind of line in the sand that we've drawn for ourselves. Next slide. So this is our decision flow diagram to help you figure out if a single dose aminoglycoside might be a viable option for your patient. We exclude pregnant patients given the lack of data. We only include patients who have cystitis, again, because we care about concentration in the bladder. And as such, we also exclude patients who have moderate to severe renal dysfunction, because again, they're not producing enough urine, that we're not getting a high enough concentration in that space. Same for patients who have significant urological abnormalities. We're just worried about them getting sufficient concentration, and so we would consider avoiding it in those situations. And then, of course, not ideal for pyelonephritis, prostatitis, or bacteremia. Next slide. And then this also comes up quite frequently. How do I dose? We made this really nice dosing table that simplifies the process. I know mg per kg dosing can be quite cumbersome, especially in the outpatient setting. And with aminoglycosides, do you use total body weight? Do you use ideal body weight? Do you use adjusted? Don't worry about that. Just use this table. It provides essentially a 5 mg per kg dose with about, I would say, 0.5 mg per kg difference with each of these regimens. And so this can be available to you. It's on our ABX site. If you search single dose aminoglycosides for ED and urgent care, you can find this table available to you. Next slide. Okay. And then lastly, moving on to clinical decision support. This is a way to essentially make the decision-making process easier for providers, providing a checklist approach to ensure that we're treating patients fairly similar across these common infectious disease states. Next slide. Okay, so Kelly referenced our upper respiratory tract infection, or URI, symptomatic prescribing pads. As you can see here, it provides some really great information on symptomatic relief. And as Kelly alluded to, gives you common duration of therapy for some of these infections, or not duration of therapy, excuse me, common duration of symptoms for some of these infectious disease states, so you can reference that when you're talking to your patients. We have our prescriber version on the left, and then we worked with our Kansas Pharmacy Task Force to create a pharmacist-specific version as well. And this was distributed to community pharmacists so that they could help with patients who come in and have concerns for upper respiratory tract infections and are looking for symptomatic management. As you may or may not know, our pharmacists in the state of Kansas can prescribe for certain infectious disease states. And so this is kind of in combination with those prescribing protocols to help aid pharmacists in symptomatic management for those infectious disease states. And then we also have a dot phrase listed down there. This is the GU version. Again, the prescriber version is on the left, the pharmacist version on the right. Notably, this is not for like primary management of a UTI, but it's just providing information on symptomatic relief and management for patients who have recurrent UTI or chronic pain due to the UTI. What's also really nice about this is that it has preventative medications and diet and hygiene advice as well, which is really useful in these patient populations. Next slide. All right, our last script pad that Kelly made this year, and again, with our focus on shorter is better, is antibiotic duration decision support. Again, providing recommendations for common infectious disease states, antibiotics, and duration of therapy recommendations. Next slide. Also, as a part of our Shorter is Better campaign for this year, we worked on some posters that can be posted in patient workrooms and other provider locations as a quick reminder on appropriate durations of therapy. On the left, we have our inpatient version, which again focuses on some common inpatient infectious disease states. And then on the right, we have our outpatient version, which is focused on some of those outpatient disease states. Next slide. And then we also worked with our task force to create some patient-facing materials. So this is a social media campaign that provides 12 different graphic posts and associated post comments that again is intended to be post for the general public to provide awareness on shorter is better and common antimicrobial stewardship principles. So I have an example of the graphic on the left and an example post. If you're curious and want to look at these posts, I have the QR code listed at the bottom there that you can scan. Next slide. Again, just to promote these posts, since Kelly worked really hard on all of these graphics are so cute. And I think the bottom left is me, which is also a great tribute. Thank you, Kelly. And next slide. And then again, here is the QR code. Okay, to wrap up my section, I really like to be able to provide institution-specific data whenever possible. And this is an ongoing topic that as ambulatory stewardship task force, we are actively looking on ways that we can track and trend appropriate antibiotic prescribing in our outpatient setting. And so this is some KU-specific duration of therapy data for cystitis on the left and sinusitis on the right. You'll see that I included urgent care and internal medicine. That's because we're pulling primary diagnosis codes for this specific data. And as you can tell, there's a lot more robust and quantity of data with the urgent care because they're only seeing patients for that very specific chief complaint, as opposed to IM clinic where you're, managing their diabetes and managing their hypertension. And then they also just happen to have a UTI when you see them. So I just wanted to show this to you all to say that we do have some areas for improvement and there is a way that we can move the needle. So looking at cystitis here, you can see that we are doing a good job at generally 5 to 7 days, but there's still a good amount of prescriptions that are in that 8 to 10 and over 14-day range. Same as with sinusitis, there's a certain amount of prescriptions that are in that 5 to 7 range, but as you can see, specifically with urgent care, there's still a good amount of people who are prescribing 10 days of therapy. And so all this is to say, we really do, as a stewardship team, want to work on improving duration of therapy. And yeah, we're really motivated to help move the needle in this area. All right, I'm going to pass it back to Kelly to talk about measles.
I feel, just to like make a point, I feel like a big takeaway for me is like if I'm ordering more than 7 days of antibiotics for essentially anything, I really have to look myself in the mirror and say, why are you doing this?
I love that.
I mean, 7 days is kind of the cutoff. So.
Mm-hmm.
Okay, so I mentioned I talked briefly at ACP about the measles outbreak. And so I just, interesting some stats that I pulled up. So we were actually during this outbreak, which was declared over in Kansas in September, the top 3 state nationally. So looking at total, rate of a population or measles cases per population, New Mexico actually had the most, followed by North Dakota, and then we had about 3 per 100,000 population. So of course Texas, because it's like 30 million, they had the most. I didn't update this since October, but they had obviously the most cases, but we were pretty high nationally. And these all cases were centered down here in the Southwest, as you know. There was out of these cases 80, so total of 90, but 87 were outbreak related and only 3 were non-outbreak related. So there were some cases that were like, travel related that came into Sedgwick. And now there's one more since then, and that's in Casey that I'll talk to you about. Interestingly, so this is the epi curve. So the cases that happened with the outbreak, the first case actually was found here in March 11th. And so then they like went back, and then that's how they like determined that these cases were actually starting to circulate on January 26th. And so really, again, this is like the epidemiologist work. A lot of people that were kind of trying to track down contacts and such. And then you could see like we would have these like naders, was hoping that, that might be settling down, but because the incubation period for measles is 21 days, you knew that there's a good chance that this people are circulating and boom, they would pop back up. But finally they did trend down. And then September 21st is when that outbreak was declared over in Kansas. And interestingly too, KDHE never said this, but I think they didn't want to stigmatize the groups, obviously, but this was basically directly the same isolate or, the same genomic as that outbreak that started in Lubbock, Texas. So the Gaines County is where it started. And so it was amongst the Mennonite community. So actually they genotyped all these isolates at the Kansas Department of Health. It's called K-Hel. It's the lab where they do that. And so that's how they knew specifically of whether they were related and also whether they're mutating. But indeed, they were imported from the Texas cases. And so that's pretty much how it kind of started. I just wanted to highlight, because I thought Kansas actually did like a So this was a comparison between what we did in Kansas compared to what Texas did. And so Kansas, they did a 21-day quarantine for exposed or unvaccinated people, or, they were exposed and unvaccinated. And they had a lot of boots on the ground. So these epidemiologists were actually contacting them daily, people that were on isolation to make sure they didn't have any symptoms. They didn't have the bandwidth to really do that in Texas. And so they didn't enforce the 21-day, isolation period either. So that was turned into like a big problem in the Texas outbreak. The other thing that we did early on in Kansas is the medical officer, Dr. Totten, implemented that we can decrease the vaccination age to 6 months. And so that was implemented for counties that are impacted and then also adjacent counties. They didn't do any recommendation for changes in Texas. And so, that was another kind of impact that we potentially to, protect kind of our most vulnerable. We also had a lot of pop-up clinics, extra clinics in Kansas. Texas, they initially early on offered them, but then because of staffing and budgetary, they had to close them. So they were actually not really able to really conduct that many vaccine clinics. And then both sides really, because this was a Mennonite population that was really vaccine hesitant, both states really did engage, and they got people within the community that they also had some interesting kind of cultural considerations. Like they had this dialect that was like German speaking, and so these people became like trusted kind of liaisons to both the public health and to the population that was being impacted so much. And so hopefully these people also continue to kind of be engaged in the public health effort. And the other thing that Kansas really did pretty good is rapid testing. So if someone is test or screens positive, like they're having symptoms, they get those isolates to KHEL, the state lab, within 24 hours. So they ship them immediately, or there's a courier that's going back and forth constantly. They didn't have the same logistics in Texas, and so they weren't able to get that same kind of rapid turnaround to make sure those people were immediately put into isolation. And then I know we're running out of time, but the measles exposure. So this is that happened in MCI. So here's the Casey Mo Health Department put out this notice last week. I think it was last week, that if you were at the MCI from November 5th from 2 a.m. to noon, and then November 10th from 2 a.m. to 4 a.m., you potentially may have been exposed to measles then, because again, the incubation period for measles is 21 days. So for patients, or if you were there, your risk, your timeline of when you might be looking at symptoms is from November 12th to December 1st. So past December 1st, if we have no cases associated with this, we're hopefully out of the clear. Any questions specifically on measles or anything? It was a very brief measles update.
Yeah.
No, Kelly, we appreciate that. And sorry, I'm getting ready to start my clinic. So I just want to say thank you to you and Megan. Your updates are always so helpful for us, and we appreciate all that you do for us.
Sure. Yeah, let us know if you have any questions afterwards or anything.
Okay, thank you.
Thanks. Great. Bye.